Okay. All right, so your vasoactive agents. You have your catecholamines and sympathomimetic agents. Dopamine, epi, norepi, which all of these you are definitely going to see. These are substances produced within the body to activate the sympathetic nervous system. It initiates your flight or flight response and stimulates the alpha and beta adrenergic receptors, causing many changes. So epi, used to support your respiratory function by opening up the larger airways. It augments blood pressure by increasing your vascular tone, has chronotropic effects and even more inotropic effects on the heart. It's given by IV during cardiac arrest resuscitation efforts, and then depending on your various clinical situations, you can give it as an IV bolus, an IV infusion, inhaled, nebulized, IM sub-Q, or administered via the ET tube. And then it's just emphasizing again that you need to make sure you're looking at reliable references for dosing instructions when your epi is indicated. Norepi, you're going to see this one a lot. It's most commonly used for your blood pressure control. Levophed. Your dopamine, you're going to see this in IV infusions. Low doses may achieve a renal effect, but it's not recommended for this use. Higher doses, you're going to increase your cardiac output with. And even higher doses increase alpha effects to increase and maintain blood pressure. So this is one that's an old school one, the dopamine. It's been used forever, but they're really going away from it just due to the high risks of arrhythmias. So they're now saying that dopamine is your last line for your pressors. And then vasopressin, this is also a naturally occurring hormone referred to as an antidiuretic hormone. And then alternatively, vasopressin can replace your second or third dose of epi during cardiac arrest. It's also one that's used quite frequently in severe septic shock resulting from vasodilation. It's also used in treatment of diabetes insipidus and certain types of GI hemorrhage. And then you have phenylephrine or neosynephrine. Don't see that one near as much. Dobutamine or Dobotrex. Dobutamine, something you want to consider when you're using dobutamine is it is not as effective for patients on beta blockers. And then milrinone, this one a lot of cardiologists like, but I don't really see it so much, and I'm not sure you guys will, but in case you do, it does improve the cardiovascular performance, and that's why they like that one. There's no bolus dose for milrinone. And then you really have to adjust your dosages for renal impairment with this one too. And then you got your nitroglycerin, which you guys obviously use this a lot. We'll see this a lot. Sublingual, topical, and IV drips. And we were just discussing at break how this one's being used a lot more in IV drips, even for hypertension. So no cardiac, just hypertension. A lot of doctors really like nitro. You can titrate it. The only thing is it really gives that like super bad headache. So your patient's like, God, I just have this super headache. Well, you're on 150 mics of nitro. You're gonna have a super headache. It's the traditional first-line medication for ischemic heart disease. And it primarily is a venous dilating agent with limited effects on the arteries, including the coronary arteries. And then your nipride. It's not as commonly used to control blood pressure, but it is effective at maintaining vasodilation. And then a weird fact about that is it's metabolized to cyanide and may induce cyanide toxicity, which is one of the reasons it's not used so much. And then Natricor, Nazaritide, produces minimal changes in the heart rate. No renal or hepatic dosage adjustments are required, but it can induce hypotension. So you want to admit bolus doses. That's one you're not going to see so much either. So this one just kind of shows some of the things to expect with them. And then you have your antihypertensive agents, your medications that affect the blood pressure. Got your beta blockers, metoprolol, labetalol, esmolol. Carvedilol, labetalol. So with all of the beta blockers, you want to use caution in patients with asthma or severe COPD due to the pulmonary receptor blockade. Your calcium channel blockers, verapamil, diltiazem, they have a negative inotropic effect. And then your ACEs and your ARBs, they treat hypertension or CHF. They're contraindicated in pregnancy. So with the ACEs and the ARBs, one thing you really want to remember is you need to monitor potassium. So if they have renal impairment, if they're on diuretics, you need to watch your use of this because it has negative effects on your potassium. And then you have your diuretics, which remove excess fluid from circulation, beneficial for your fluid volume overload, your cerebral edema, and your rhabdo. With diuretics, since they're removing all that fluid from the circulation, you need to use in caution when you have a patient that's dehydrated, hypotensive, severe electrolyte imbalances, or alkalosis. Alpha-2 agonists is your clonidine. Hydralazine, direct vasodilator. This acts directly on the arterioles, which produces vasodilation and lowering of the blood pressure. So with hydralazine, you need to use caution with angina or an MI, elevated ICP, or an aortic dissection. So preferred agents for hypertensive crisis. And this was just another little slide for it. You're not going to see too much of this. Aortic dissection, you're probably going to see nicardipine drip. That's the most commonly used one. Heart failure, you got nitroglycerin. Acute MI, nitroglycerin. And then you have your antiarrhythmic agents. The management of cardiac arrhythmia involves several classes of antiarrhythmics. So obviously you're gonna really want to watch your arrhythmias and your EKGs with these patients. So these are all classified based on the Vaughan Williams classification scheme. Your class 1 antiarrhythmics increase the refractory period. There are drawbacks in patients with pre-existing infarctions or structural heart diseases and tend to have significant adverse reactions. So your class 1A, procanamide, your class 1B, lidocaine, and then your class 1C, flecainide. The class C, your life-threatening arrhythmias are going to originate in the ventricles. And with the class C, you're going to avoid in patients with heart failure post-MI. And then class 2 antiarrhythmics or beta adrenergic blocking agents bind to the beta receptor sites to inhibit its stimulation. The newer drug class used in treatment of arrhythmias, hypertension, MIs, and congestive heart failure. So this is your metoprolol. You're going to see this a lot. It decreases the automaticity of the heart tissue, which in turn it decreases the cardiac output and blood pressure. Contraindicated in severe congestive heart failure, bradycardia, or cardiogenic shock. So Mercy, if you're giving metoprolol, it tells you you can't give it if their heart rate's less than 60, because you don't want to push it down too much. And then esmolol, it's a shorter acting beta blocking medication, and it's contraindicated with AV blocks or uncompensated congestive heart failure. And then you have your class 3 potassium channel blockers used for treating re-entry tachycardias and arrhythmias. You got your amiodarone, which is your most common. You're going to see that a lot. Can precipitate torsades, AV blocks, and bradycardia. And again, it's just reiterating to consult your reliable medication reference source for dosing. Ticacin, hardly ever see that, but it is contraindicated with any other class 1 or 3 antiarrhythmics. And then Moltac or dronedarone, it's similar to amiodarone. And then your class 4s, calcium channel blockers, which cause vasodilation, used for treating tachyarrhythmias originating in the atria. And the only two really that you're going to see for treating arrhythmias are verapamil and diltiazem, or cardizem. Cardizem more commonly. And this one you're going to see quite a bit in transport, cardizem. Atrial fibrillation. And then you have adenosine. It's a different type of antiarrhythmic, and it's actually classified as endogenous nucleoside. It's a naturally occurring protein, and it's a substantial part of cellular metabolism. And then adenosine can restore the sinus rhythm in patients who have paroxysmal SVT or narrow complex SVT. It's not really effective in converting AFib, but can be used as a diagnostic tool. So if you're not sure if you're in AFib or you're SVT, if it's administered for irregular polymorphic wide complex tachycardia or VTAC, it can cause deterioration. So you have rebound hypotension. And then adenosine has an exceptionally short duration of action, so 12 seconds, given as a rapid IV bolus followed by a rapid IV bolus of normal saline. So they say that even having a wide open line and pushing adenosine, it's actually more effective if you have like a 3-way stopcock, or you flush super fast after you do that adenosine and then put their arm up in the air. Adenosine contraindications: patients taking Tegretol or Prasantin. And if you definitely need to use it, you can reduce the initial dose. So your initial dose is usually 6 milligrams. If you have contraindication, you can reduce your dose to 3 milligrams for that first dose and then do 6 milligrams for your second dose if you need it. And then you have anticholinergic medications, so atropine. Blocks the receptors in the parasympathetic nervous system. It's the first line therapy for sinus brady because it begins working immediately. It's not likely to be effective in patients who have second and third degree heart blocks, but it's still used for it. And then they no longer recommend atropine for the use in PEA or asystole because it's unlikely to have a therapeutic benefit. Many RSI protocols still use atropine as prophylactic medication to prevent bradycardia from succinylcholine administration, especially in PEDS patients. And then the toxicity part of that, for the emergent treatment of acetylcysterosis inhibitor toxicity, which is like certain pesticides and chemical nerve agents, atropine, you're going to use for that. And then you're going to monitor your patients for dizziness, palpitations, GI upset, arrhythmias, and anticholinergic effects. So then you have your electrolyte replacements. IV calcium is indicated in numerous clinical situations. Obviously, hypocalcemia to prevent cardiac arrhythmias associated with hyperkalemia. You can give it IV to treat hypotension or bradycardia associated with calcium channel blocker overdoses. It's actually the antidote for magnesium toxicity and hydrofluoric acid toxicity. But you need to use extreme caution when you're giving IV calcium. It causes significant extravasation and tissue necrosis, especially from calcium chloride. So they recommend calcium gluconate if not being used during ACLS. And then your possible side effects: hypotension, vasodilation, arrhythmias, syncope. Magnesium sulfate, presumptive hypomagnesia, ventricular cardiac arrhythmias, anticonvulsants for preeclampsia and eclampsia. It's a very versatile medication. It's frequently carried and encountered by critical care transport paramedics. It's used to treat low serum mag levels, like I said, the presumptive hypomagnesia. Aggressively treats ventricular cardiac arrhythmias, so obviously torsades, VTAC, VFib. But the use in the OB patients is becoming controversial. However, it is still considered the first line anticonvulsant for preeclampsia and eclampsia. It's also used for asthma exacerbations. IV infusions, it can cause respiratory arrest or hypoventilation, hypotension, vasodilation, cardiac conduction abnormalities, a very flushed feeling when it's given. And then you got your potassium chloride. Your indication is obviously hypokalemia, which can be very vague. Obviously, your adverse reaction here is going to be hyperkalemia. And potassium is very essential for nerve and muscle tissue function. And then your sodium bicarb. So typically, if you're giving sodium bicarb, you're going to be giving calcium with this. It's electrolyte with a powerful alkalization effects. And it's typically used for metabolic acidosis. Numerous electrolyte abnormalities and alkalosis are side effects. So you could have hypokalemia, hypocalcemia, and hypernatremia. So this is another little slide that just shows your basics: hyper and hypokalemia and calcemia. Your deficiency, what the norms are, things that can cause it, things you can see, and then your EKG changes. So hypokalemia, the big EKG changes, ST depression or prolonged PR interval. Hyperkalemia also has ST depression, but it has tall, tinted T waves or absent P waves. Hypocalcemia, you got your prolonged QT, and hypercalcemia, your shortened QT or depressed and widened T waves. So patients that are deficient in a lot of these, the first things that they're going to complain of is muscle cramps, Charlie horses, weakness. And then we have the analgesics. So we have non-opioid analgesics. So your salicylates, your acetaminophen, your NSAIDs. So patients experience pain resulting from illness or injury may benefit from any of these, and medications that relieve pain are referred to as analgesics. Opiate-based medications are not the only medications with analgesic qualities that are used by you guys. So ketamine, we talked about that one for sedative effect, but ketamine can also be used as an analgesic quality medication. Acetaminophen, Tylenol, obviously, your NSAIDs, Toradol. Toradol is very common. It's only used for short-term or acute pain. You're never going to see somebody getting Toradol for chronic pain complaints. And then obviously with your NSAIDs, you need to be aware that they can cause bleeding, perforations, gastric ulcers. You got different routes, IV Toradol, then you got your PO, your ibuprofen, your diflunicate, your naproxen and indomethacin. Okay, so then you got your opioids, medications that are CNS and respiratory depressants. So fentanyl, you see this one all the time. Rapid acting, very potent, relatively short duration of action. So it's synthetic opiate that is said to be anywhere from 75 to 200 times the potency of morphine. So that's just something to think about. Morphine, you're also going to see that. Very popular in pre-hospital induction of analgesics. It alleviates pain through CNS depression, suppresses fear and anxiety. With morphine, you want to take care to prevent hypotension, so you're not going to give morphine to somebody that's already hypotensive, and it can cause respiratory depression. So there's the two big ones you're going to see, but then you also have Dilaudid too, hydromorphone. And then you can see on here your onset. Fentanyl is obviously the quickest. Dilaudid and morphine are going to cause hypotension. Dilaudid and morphine are going to cause flushing. And then you have your medications used for neurological conditions. So neurological illnesses, diseases, and conditions that are commonly seen during your transport. Anesthetics, anti-anxiety, sedatives, and hypnotics. Benzos, they should be considered the first line sedative medications during critical care transport. You got your first generation, so Halidol. Antipsychotic can sedate combative patients and those experiencing psychotic episodes. It's not approved for IV administration, but it's often used IV off-label with emergent control of agitation is desired. Your goal is to achieve sedation with the lowest possible dose because of potential for a fatal condition known as neuroleptic malignant syndrome. And then you definitely need to be prepared for the potential of those extrapyramidal symptoms, so involuntary muscle contractions of basically the entire body, the face, the neck, the trunk, or any extremities. And then that Haldol does cause QT prolongation. So they really watch this in the hospital. And then you have your second generations, which are Zyprexa, Geodon. You're definitely going to see both of those. If you administer them IV, they will start producing an effect within an hour, producing dizziness, drowsiness, and potentially orthostatic hypotension. And then you have your ketamine IM, much higher doses with IM for agitation. The average time to onset of sedation is 20 minutes. And then some adverse reactions. They can produce vivid dreams, further hallucinations, tachycardia, hypertension, and respiratory depression. And then a newer one that we're seeing quite a bit here, Presidex, used in intubated patients, but it's also approved for sedation in non-intubated patients. It produces sedative effects within the cardiovascular and respiratory system, but it doesn't compromise it like the other ones. So I know, like, a lot of times now they're using this in place of propofol in the hospital. I've only seen it a couple of times, but a lot of the critical care doctors are preferring this now. And then you have your anticonvulsants. So initial pharmacologic treatment of seizures in pre-hospital and critical care transport should be done with IV benzos. But you also have rectal diazepam if you don't have IV access. And then you have your Dilantin and your fosphenytoin. Dilantin is an anticonvulsant prescribed to patients with seizure disorders or status epilepticus. And it can cause cardiac arrhythmias, VFib, AV conduction abnormalities, and hypotension. And then your extravasation of IV Dilantin causes the purple glove syndrome. And then Cerebrix, or the fosphenytoin, is a chemically modified form of Dilantin, but has the reduced risk of infusion reactions and can be administered at a faster rate. So less harmful side effects when there's some leaking of the IV into the tissue. And then you have your alternative second line options. So valproic acid or Keppra are considered alternative phase 2 treatment options, which means there's no clear evidence that any one of the three options is better than the other one. And then phenobarbital is well tolerated, but its slower rate of administration makes it an alternative to Dilantin, valproic acid, and Keppra. Traumatic brain injuries and trauma. So your goal here is to reduce the ICP. You're probably going to see mannitol or hypertonic saline, so 3% saline, which is usually a bolus dose, 250 to 500, and then control bleeding with TXA. So mannitol is your common treatment choice for increased ICP with traumatic brain injury. It's an osmotic diuretic. It does cause significant changes in electrolyte levels. And then your hypertonic saline is your alternative to mannitol. And again, evidence doesn't show that one is better than the other. but central administration preferred due to osmolarity and risk for phlebitis. But it can be administered peripherally. So if you have a central line, you want to use that. If you don't, you're going to use your peripheral. And then your TXA, you guys might see this. It's becoming a more popular thing, even though it has been around since the 60s. It inhibits fibrinolysis to reduce the bleeding and the need for blood transfusions. It's part of a massive transfusion protocol, not ours in the hospital, but I have seen it quite a bit. And then there's a lot of indications for patients requiring lots of blood products, hemodynamic compromise, secondary to hemorrhage, risk of hemorrhage, and unresponsive to fluids. So you're going to treat or prevent major blood loss and traumas, nosebleeds, postpartum bleeding, and surgery. So frequently, obviously in traumas, this would be IV medication, but they use it PO a lot in nosebleeds, postpartum bleeding, surgery, and even they're saying that they're using it more in women that their ministrations are longer, but it is pretty expensive. And then alternatively, it can also be used in hereditary angioedema. I've never seen it used for that. IV or oral, and then in a trauma type setting, it's a gram over 10 minutes, which is the standard. And then this is indicated with some indication criteria. So age greater than 16, evidence of significant blood or penetrating traumatic injuries, evidence or concern for severe internal external hemorrhage, so pelvic fractures, bleeding that requires a tourniquet, long bone fractures, sustained systolic blood pressure less than 90, sustained heart rate greater than 110, so shock. And then time since the initial injury is known to be less than 3 hours, because that's when it's going to be most effective. The book didn't go a lot into the TXA, but it's an up-and-coming thing that's going to continue to get bigger and bigger. So here's just some of the ways it can come. You got the 500 milligram tablets, which are the PO tablets, and then all your different IV stuff there. And then this is just a little thing on the TXA mechanism. So it breaks the fibrin clot, and then TXA interferes with the binding site. And then you got your antidotes. So Narcan, the most common example used in pre-hospital and critical care transport. And then patients with apparent opioid intoxication should receive only enough Narcan to restore effective respiratory functioning. So it's basically saying lowest dose possible. And then romazicon, flumazenol, treat your benzo overdoses. Use with extreme caution because it can induce seizures. And then it's very limited in critical care transport. And then glucagon, endogenous peptide produced in the pancreas that has been replicated commercially. It's a rescue agent for acute hypoglycemia in patients without IV access, an antidote in overdose or toxicity symptoms, and it's usually packaged in powder form. And then you have to reconstitute it. Narcan, you guys probably have all seen this before, but standard doses for OD or respiratory depression in drips. 0.2 milligrams to 2 milligrams. They say you shouldn't exceed 10 milligrams. And it can be continuous infusion. I've seen it a couple of times. Alright, so now you got your medications affecting the GI systems. Easily underestimated, but you guys are going to use this quite a bit. Numerous conditions related to transport can cause nausea or vomiting that requires treatment during your transport. You got your 5-HT to the third receptor antagonist, or your Zofran, your ondansetron. The serotonin antagonists are believed to cause their effect by selectively blocking serotonin receptors in the medulla, to suppress the vomiting centers. These have a really low dose adverse reaction, which is why it's used so widely. Dopamine antagonist, effective in reducing the nausea and vomiting. So you got your promethazine. IV administration should be avoided due to severe tissue damage. If you have to use it, it should be diluted and infused slowly over 15 minutes to prevent phlebitis. Don't see Phenergan very much anymore. And then your compazine, contraindicated in patients who have bone marrow disease or severe liver or cardiovascular disease. It can cause Parkinson-like syndromes and produce those extrapyramidal effects, so the tongue flapping, the shaking, stuff like that. And then you have your Halidol and droperidol. Again, QT prolongation, but in low doses effective for nausea and vomiting. And we do use the Halidol quite a bit for nausea, vomiting, headaches. Then you got your prokinetic, your Reglan, your metoclopramide. Similar action on the D2 receptors with the added benefit of increasing GI motility. And your anticholinergics, your scopolamine, and your H1 antihistamines, Benadryl, meclizine, which you'll see those quite a bit. And then you've got your others, or your dexamethasone. And then you have anti-secretory agents. So octreotide, treatment of upper GI bleeding. We use octreotide quite a bit. Your GI bleeding is obviously fatal, a fatal medical condition. And then your somatostatin, naturally occurring peptide chain that decreases the intestinal fluid secretion, slows GI motility, reduces portal blood flow. It's replicated pharmacologically for management of bleeding from esophageal varices or other disorders, and has a very limited use due to its short half-life. Octreotide, your synthetic peptide. It's got a longer, more clinically useful duration of action, but you also have a lot of side effects with octreotide. So bradycardia, chest pain, fatigue, malaise, headache, diarrhea, and abdominal discomfort. But if you're using octreotide, you're not going to worry about that stuff. So you have your respiratory management, or your medications used in respiratory management. Effective respiration requires both the movement of air in and out of the lungs as well as the gas exchange. Your beta agonistic medications act upon receptors in the lower airways to improve airflow in and out of the lungs. And then you have additional medications to improve oxygenation and ventilation through further bronchodilation, inflammation reduction, and secretion control. And then you have various inhaled gases and exogenous surfactant appear to improve oxygen delivery and exchange in patients with respiratory disorders. So, beta agonist medications, beta 1 receptors found in the cardiac tissue, increase the heart rate, cause cardiac muscles to contract, produce automaticity, and trigger cardiac electrical conduction. And then your beta 2 receptors are found in the peripheral vasculature and in the respiratory tract. So these stimulate vasodilation and bronchodilation and are used in the treatment of asthma, RSV, bronchitis, emphysema, but also can produce some beta 1 effects. So your most common you're going to see your albuterol. It's a selective beta 2 agonist. With albuterol, you can have cardiac manifestations, tachycardia. That's something you're going to see. Other side effects include insomnia and dizziness. With the albuterol, the benefits tend to outweigh the drawbacks, especially in the younger populations, the peds. Used to treat patients with severe asthma, COPD, or other reactive airway exacerbations. And you can do a continuous albuterol nebulizer regimen. So a lot of times we'll do like a 1 hour or like a 90-minute continuous nebulization in the hospital. Your levalbuterol or your Xopenex, it's very new, and it's the more expensive alternative to albuterol. And then you have your terbutaline, your breathine. It's a beta-2 agonist used as a bronchodilator. Commonly used as a tocolytic, but it is not FDA approved for that, and it's contraindicated in the patient with tachycardia. And then your non-selective beta agonist medications, or your epi or your racemic epi. Racemic epi, you're going to see a heck of a lot in the peds population. And then your mucinetic and bronchodilator medications, or your Atrovent, your apatrobium bromide, Duoneb, concurrently used with albuterol, reduces the mucosal secretions in the airways, dilates the airways. And then your thephenyline, which isn't up there, but it's not commonly used in the acute setting. In conjunction, you're usually going to have your corticosteroids, which treat the inflammation of the airways. So your prednisone, your methylprednisolone, which are very common in your emergency and critical care settings. And actually, these are all contraindicated in patients suspected of having infectious disease processes. So dexamethasone, Decadron, it's being used less commonly because of its associated complications, including severe infections, hyperglycemia, hypokalemia, and myasthenia gravis. And then your prednisolone. This is also another very common one. It has the lowest percentage of placental crossing. And then we have your allergic reactions. So your H1 and your H2 antagonists, diphenhydramine, your Benadryl, famotidine, your Pepcid, mild sedative and sleep aid, and also available over the counter. Can be used IV for the same purposes. Has adverse effects on, adverse effects of Benadryl are tachycardia, palpitations, chest pain, drowsiness, dizziness, ataxia. And like I talked about back in the beginning, Benadryl can also be used for a headache in conjunction with like Reglan, the dexamethasone. And obviously these are used as push medications. You want to push your Benadryl pretty slow. Your patients are going to feel like they're having a heart attack. Okay, let's take another quick break just because I feel like I've talked a lot before we start these antiplatelets. I don't think I'm going to use 4 hours, Sarah.
I know I will.
I feel like I talk too fast. I do have a Sweet Jeopardy game though.
Oh, yeah?
Yeah. And candy.
I like Jeopardy. I'm bad though, because I usually don't know the answers. Or I'm afraid to say it.
Well, I made it all like stuff that I like talked about in here.
Oh,
It's not very long, but
I've actually been working out, so I'm like stiff.
yeah, I know, me too. It's terrible, isn't it?
What you're asking me here?
Do you guys have something in the afternoon too?
Yeah, I think Lee's teaching this afternoon.
Oh, really? What is he teaching?
Shock.
Better him than me. Actually, I don't mind Chuck.
I do like the GUGI workout.
Yeah, when do you have to teach that?
May 9th.
Did he give you your outline or whatever?
Yeah. He's like, I was like, I thought I was just doing like.
Yeah, because didn't you say that your section is 4 hours too?
Yeah. I thought I was just doing a little snippet, and I was just like, I gotta do all of that.
I know. Well, he sent me the outline for this, and I was like, holy, it was like 75 pages. I was like, nobody's gonna retain that information. Like, most of this is bullshit.
Yeah.
And basically,
like, I've been looking through some of the stuff, and it's like a lot nursing based.
well, yeah, that's how I felt too.
Which, I mean, it's through like going from hospital to hospital.
Yeah, and that's what he said. He said to make sure to just, like, at some point focus on, like, double checking your drips.
Yeah.
Which you're gonna be doing that.
Yeah. Oh.
I know.
Remember, were you on weekend 3 too?
We're on 2, aren't we?
I'm on weekend 3.
I thought you were on my weekend.
Well, I've been working all sorts of weekends because people need switching.
Wait, maybe we are weekend 3. Are we supposed to sign up right now?
Well, that's what I should look because,
Shoot.
or was it Friday? I think it's Friday.
Okay, good. Because it was weekend 1 for, I don't know. I always forget what weekend I'm on.
Or 2 was first.
I think every month I text Christy Soul and ask her what weekend we're on. She's like, it hasn't changed it in 3 years, Amanda.
Yeah, we start Friday, tomorrow.
Okay.
Well, that's like Corey. I've been like working so many odd weekends, and he was just like, "Why are you doing that?"
I do that all the time. That's why I get so confused.
And I was like, "Well, just because."
'Cause I trade all the time.
Off. And we're like, it's winter. We don't do anything. He was like, one of them was his Kelly Day weekend. So he had like 5 days off, and I worked 3 of them. I'm like, well, that was dumb, but oh well. We'll go camping though once it gets nice out. So I'll have to watch it for that. But.
So is this strictly like you guys have to take a test at the end, or do you have to do like sign off things?
We have to do
Quizzes? Do you have quizzes?
Yeah, we have quizzes every week and tests almost every week
Ugh.
that we have to do.
Is it open book?
Yeah, it's
Oh, that's
online.
good.
Yep.
Adam, what's the stuff in the end? Because we coordinate at Sound as like we really just take the class, do the skills like thing at DMAC, and then that's it.
And then we have a 48-hour just clinical. I think it's just get us out there and just,
Oh, there is a clinical with it?
Yeah. There's sometime in ICU. I think
Can I
sometime
go
in
Methodist, please?
sometime in respiratory, I believe. He wants to get us on the helicopter a little bit if he can. So.
Yeah, I wonder if I can go to Methodist because I know our ICU.
Oh God.
They'll know.
They'll
who
totally
I am.
recognize you. Yeah.
They're
Yeah,
not
that
trying.
sucks.
So.
Yeah.
Is it just your department that's, or are there students from? other
There's a
places?
few other people from different
pause that?
places.
No, I don't think we did.
Well, let's have to go in my favorite.
Honestly, you guys are gonna get out of here earlier.
We are
than-
not doing too good.
I'm not gonna take 4 hours. Like, I'm almost done. But then I have the PowerPoint for the pump, which you guys don't have, and that Jeopardy game. You're gonna be on YouTube if your head's in there, so.
Yeah, bathroom, drink, and yeah.
Did it work?
Sorry, we haven't said anything. I forgot they were recording.
was being recorded.
It's not.
No,
I don't know sign language.
it's still recording.
It's not recording voice. Don't worry.